Hello, everybody. This is Dr. Joshua Goldenberg. I am with the very esteemed Dr. Mark Davis, who is a naturopathic doctor, professor, researcher, and FMT enthusiast. And I don't know anyone that knows FMT research better than Dr. Davis. And so I wanted to invite him on. So welcome.
Thanks for inviting me.
Fabulous. So I wanted to get your thoughts, and maybe we could just kind of riff and talk for a little bit about where the state of FMT research has been and where it's going, et cetera. You know, we review a lot of the randomized controlled trial data anyway that's been published on FMT, and I'm kind of curious to get your overall perspective on where we are. Because I look online, I go to clinicaltrials.gov every once in a while, and I just for fun, I'll type in FMT, and there's like all this stuff being done, but very little published. So maybe tell us a little bit about what your thoughts are on that.
Wow. Okay. So historically, you probably know the first mention is 1700 years ago, an author named Gehung. And then in the 1800s, there was another Chinese author. And then there's a European author, Christian Franz Paulini. And then in modern times starts in Colorado, 1958, I think, Eisman et al. University of Denver, I think, medical school. Anyway, but then that was like the first report in modern times in the 50s, and we got smatterings here and there until the 80s, and Thomas Brody in Australia publishes essentially just a case series of IBS and IBD patients. And then our first real randomized controlled trial was randomizing people to either FMT. It was either 4 days of vancomycin, high-dose vancomycin, followed by FMT for refractory C. diff, or standard vancomycin taper. Mm-hmm. I think that trial was ended early because of the much better outcomes in the 4 days of vanco followed by FMT group. And there's been kind of an explosion since then. What we have, our highest levels of evidence are, there's plenty of evidence in for RCDI now, for refractory C. difficile infections.
So how many RCTs are we talking? I know that. I know it's FDA approved, but I never, we're talking
It's not FDA approved.
Oh, it's not FDA approved?
No, it is not FDA approved for anything. And essentially, whole stool FMT will never be approved for anything because it's defined as a drug and a biologic because it involves living microorganisms, so it's a biologic, and it's a drug because it very clearly can be used to prevent and treat disease. But one of the hard and fast criteria to approve a drug and a biologic by FDA is that the manufacturer can show each batch is essentially the same.
Which would be impossible.
Impossible.
Samples, gotcha.
Impossible.
So then my terminology is wrong, but what is the difference then with refractory C. diff? Because I have GI docs doing that all the time here in the hospitals.
Yeah. The FDA's rule is that FMT can only be provided within the context of an FDA-approved clinical trial. But
even for refractory C. diff.
Yes, that is their rule. But they've said, we will apply discretionary enforcement of our rule. That's the term they use, discretionary enforcement, for clinicians who are using FMT for patients with C. difficile infections not responding to standard therapies.
Okay. So basically, not approved for anything, and the way we are collecting the actual fecal matter, your argument is it probably will never be approved because it'll never be batch to batch. It'll always be different, of course. But the FDA has kind of said, well, we're not going to enforce this for you guys if you're going to be doing refractory C. diff.
Right, because it's so clearly life-saving. Okay. A few other maybe worthwhile notes there. There are 8 or 10 or 12 companies who are seriously in the arena of trying to get an FDA-approved equivalent microbiological product approved for C. diff infections.
A standardized stool?
So there is a company who is taking donor stool and trying to get FDA to approve their standardized process where they kill off everything that's not a spore former, I think, with alcohol, and then they're left with just the spore formers, and then they give those to people. I don't know that FDA would, in the end of the day, go for it. There are other groups who are literally culturing out what were previously considered to be unculturable microbes. And they have batches of them going, and they have different combinations that they're separating and recombining and trying to use really a lab-grown, cultured product for C. diff.
Interesting. So just the bugs at a
Just
certain at a certain distribution that they view healthy.
Right. They're making, well, so, I mean, with, you know, they're using a few dozen bugs. There are thousands of bugs that can live in the human gut, and, you know, 100 or 200 that are living in any given person's gut, and they picked out, well, it depends on the group. Different groups are doing different things. The one I'm most familiar with has picked out like 30, I think, bugs that they think has the best chance of, you know, quickly transforming primary bile acids to secondary bile acids, so C. diff never wakes up from its spore form, and doing other things that we think can be helpful in healing and curing C. diff. So
interesting. Interesting. Well, that is absolutely fascinating. I mean, I'm sure we're many years down the road from that. And so, you know, one thing I was curious about, you know, I remember we got all so excited about the C. diff literature. I mean, we had like, what, 90+% cure rates. I mean, they use the word cure. Like, when do you see that, right?
Well,
so, I mean,
for infectious disease, I think you...
Right, yeah. It's just amazing, right? And then stuff started coming out in other fields. I just feel like the expectation was so high. I remember when the UC stuff came out, you know, I think something like 60% efficacy rate, and I was like, man, that's pretty good for like any drug, but it was almost like a downer because it wasn't like an immediate cure of ulcerative colitis.
Yeah. You know, I say I mean, there's been two good randomized controlled trials. There's Paramsothi et al. That's Thomas Brody's group, and there was Christine Lee's group, who's I'm forgetting the first author on that one, but that's the group out of Canada, and they used similar primary endpoints of clinical. One was clinical remission with complete mucosal healing, and the other was clinical remission with at least partial mucosal healing. So they weren't even just going for clinical remission. So for the primary endpoints, it's really like a 20% delta. But placebo is pretty good.
Yeah.
If you look at the meta-analyses for our best non-corticosteroid induction of remission agents, which are the biologics, none of them hit 20%.
Yeah, that's like a number. That's a very, very impressive. That's like a number needs to treat of 5 or something, right? Yeah, there's very few interventions that are that good for any condition.
Yeah, and I will say it also looks super duper 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 safe. There's zero serious adverse events that have been definitively associated with fecal transplant, aside from the delivery method, where, you know, if you're using a colonoscope or an upper endoscope, you can get a perforation.
Well, let me ask you about that. Well, it's the perforation, yeah, absolutely, and I don't mean to gloss over that. But I'm curious because, you know, one thing we think about in the research literature with adverse events is that RCTs are not the best way to track adverse events because, you know, RCTs, maybe you've got a score or 2 score, or maybe 100 people, right? And so you'll miss a lot of but less frequent adverse events. So, you know, oftentimes we get good adverse event data from like observational studies and things like that. So is there any attempt to track, with all these people doing FMT, I mean, are there tracking adverse events at all?
Yep. So it's just a couple years old, but Dr. Colleen Kelly, who's a gastroenterologist in Providence, Rhode Island, and she's really one of the geniuses of modern FMT. She's published extensively, super good, compassionate clinician, and she has established, along with NIH, FDA, I'm forgetting the major players, an FMT patient registry, where clinical groups are all around North America who are routinely using FMT for their RCDI patients, are inviting those patients to register with them, and they're just going to follow them for years and years and maybe decades and try and find out, hey, are there any statistically significant increases or decreases in any other pathologies we're looking at?
Oh, that's fabulous. Okay, so that is in the works already.
Yeah, it's a couple years only, so a couple years old only, so we don't have any data yet.
So clinicians would register with her group, and they're out in the field doing FMT every day, we would imagine. And so if they do have an adverse event, they report it to her, and it's like an open database or something like this.
Yeah.
Oh, very interesting. Okay, cool. So yeah, so that kind of answers that question. That's always been a question of mine. I mean, I know that the screening protocols are very thorough, but it's always been it just seems like such an heroic medicine in a way that I guess we would be additionally cautious. So I'm curious, where do you see exciting? I mean, I'm excited about a delta 20, to be honest. Like numbers needed to treat of 5 is pretty darn good in my book. But where do you see really exciting research coming? Because you talk to some people, it's like FMT is going to save the world. I mean, it's C. diff just like knocked it out of the park, and now it's just a matter of time until all these studies are done. I mean, are there ones that you're really excited about? Like, yeah, this is going to be a game changer, or it was just C. diff?
It's not just C. diff. I think inflammatory bowel disease is about 75% of my practice, and both in the literature and also in my practice, I've seen FMT be a game changer for patients with ulcerative colitis and Crohn's disease, both of those indications. And there's no randomized controlled trials out there for Crohn's yet. There's only open label stuff and case reports, but I can tell you from my clinical experience, the remission rates seem indistinguishable, if anything better for Crohn's colitis.
Interesting.
And I've got some case studies, and there's some in the literature of people with RCDI and Crohn's that involves the ileum getting FMT capsules and hitting clinical remission, sometimes for the first time in their diagnosis.
So you're excited about the Crohn's data coming out?
Yeah, I mean, I actually haven't looked carefully enough on clinicaltrials.gov to know how soon that's coming, but right. I'm very excited to see the results of that. And I'm anticipating from down here at the clinical level that it's going to look really good.
Interesting. Okay, so Crohn's, any other ones that you get really excited about?
Well, there's IBS. I subscribe to Dr. Journal Club, and I've been following the videos. And then, do you know there's a Danish group that's even more recent, that's just December 2018 in gut, who, let me see if I can find the author. It's like Sophie Halkier. And their group, this Danish group, did a systematic review that was published in one of my favorite journals, World Journal of Gastroenterology, in June 2017. Can fecal microbiota transplantation cure irritable bowel syndrome? What they found was no randomized controlled trials at that time, and they found basically like, okay, here we go, 6 conference abstracts, 1 case report, 1 letter to the editor, and 1 clinical review. Total of 48 patients at that time.
Oh, wow, okay.
So not a lot. Mm-hmm. And then Janssen published in Lancet Gastroenterology and Hepatology in January of this year and found pretty good looking results for irritable bowel syndrome. I think also like about a delta of 20, if I remember correctly. And then Halkier and her group in Denmark published in December in Gut, the trial Fecal Microbiota Transplantation Alters Gut Microbiota in Patients with IBS, results from a randomized double-blind placebo-controlled study. And they found a statistically significant difference in favor of placebo.
That's very interesting.
Yeah, it was a big difference. Difference on the IBS SSS. And they were given capsules.
Interesting. And that's an interesting question too. So IBS, we're unsure, but you're kind of curious about where that's going to go. So that brings me to like another side interest things. The delivery mechanism, right? I mean, like I know enemas are very relatively easy for patients, but I believe there's movement towards these like triple encapsulated pills. And then of course, within the hospitals, within the GI practices, you can do the colonoscopy or the endoscopy introduced versions. I mean, will it be condition specific where it matters? I
think so. I think so. The first open label IBS one was Larry Brandt and Olga Ariadnes and their group in New York. And they were doing upper endoscopy. It was open label. And they were like, hey, this looks like good results. But then the Norwegian trial, that was colonoscopic, I think. And they got great results, the randomized controlled trial. And then this group in Denmark was doing capsules, and they got terrible results. It was statistically significant in favor of placebo. So I would say, let's hold off on the capsules for IBS.
Interesting. Very interesting. Yeah, it'll be neat to see, because I'm trying to remember now. I reviewed them a while ago, and we'll be putting them in this collection of videos. But for the UC RCTs, for the ulcerative colitis RCTs, there were I'm remembering like 3, maybe there were just 2, but they use different ways of introducing the FMT too, right? Or no?
Um, for the ulcerative colitis ones,
Mm-hmm.
I think Paramsathy was an initial colonoscopic administration, and then like enemas 5 days a week for 8 weeks or something like that.
Okay.
And then Christine Lee's group, I'm forgetting the principal author, that was I think that was enemas only once a week for 6 weeks, something
So
like that.
then we're talking about dosing frequency. Yeah, so that's the other thing too is, I wonder how much of this is just so early that, there's so few data points that it's really hard to say, okay, well, that didn't work because it just doesn't work, or we didn't get the frequency right, we didn't introduce it in the right way, et cetera, et cetera. So that'll be a whole nother ball of wax, right? What's the frequency? How do you write a SIG for FMT type of thing?
Also, what are the microbes seems to be critical. There was an early August 2017 trial, Mizuno et al., in a journal called Digestion. Bifidobacterium-rich fecal donor may be a positive predictor for successful FMT in patients with irritable bowel syndrome.
Interesting.
So they were looking at what was the concentration of bifidobacterium, and essentially what they found is donors who had low bifidobacterium giving to patients with IBS who had higher bifidobacterium, no benefit, and the opposite was true. Donors with high bifidobacterium to donors with low bifidobacterium, good-looking effect.
Very curious. Yeah, I'd love to see it. So it's so tempting to make generalization statements, but I guess like the number of conditions studied are varied. The way we're doing it is varied. Then there's just random chance too, right? And then the N on these studies are so small too, right? So it's like how many people, et cetera, et cetera. So yeah, so very, very interesting. I know we only have you for a short amount of time today, but what the Doctoral Club audience. I mean, these are mostly clinicians that are usually integrative functional medicine minded, but also conventional care. And they're into the research, right? They're geeky, right? That's the point of it. So what do you have, any last words you'd like to say to them about, the future of FMT, both research or in practice?
Well, it's almost more the present that I want to comment on if I have a closing statement, which is what is our philosophy as clinicians that guides how we're using it? And really what I would say is the enteric immune system is influencing immune systems. And so when patients appear to have pathology that's associated with hyperinflammation and their gut microbes might be involved, FMT could be indicated. The hepatic encephalopathy paper blows my mind. Small N, but amazing outcomes. Mm-hmm. Autism spectrum disorder, we only have an open label trial, but real good looking preliminary stuff. Other things like seizure disorders and alopecia, I forget, alopecia universalis or alopecia totalis, I think. It's just a couple papers, but very interesting. Multiple sclerosis, chronic fatigue, sepsis, all of these. What is the common thread? That our immune systems are being hyperinflammatory. So if you are talking to patients about the safe, potentially effective use of home FMT, and they're doing this at home, like many of my patients are coming to me and interested in doing this, how do you counsel them responsibly? Well, just one thing to guide your thinking is what is this hyperinflammatory? And if so, is it connected to the gut microbiome? And if so, yeah, maybe FMT will help.
Fascinating. Very, very cool. Well, everyone, thank you so much for listening. This is the amazing Dr. Mark Davis of the, tell us your website. So is it the IBD clinic or? IBDsolution.com is, or markdavisnd.net. You can find a lot of my writing and interviews and stuff on markdavisnd.net and IBDsolution.com. This is remote care for Californians with inflammatory bowel disease. Awesome. Well, Dr. Davis, thank you so much for your time. It's always a pleasure. I appreciate it.
My pleasure.